Good day, dear great surgeons. Today we're gonna study our important chapter in MRCS, oncosurgery and transplantation surgery. Those are short chapters and direct question in the exam. You can grant their 3 marks or 5 marks that will come in the exam. And by the way, they are overlapping with the pathology. So we won't get deep within those chapters, just like other chapters, and we will focus on the oncosurgery and the transplantation surgery out of the scope of the pathology as much as possible because we will broad our scope within the pathology chapter. God be with you and let's crack it together. Together we can. These great surgeons take care. Regarding the lung cancer, we have non-small lung cancer and small lung cancer. The lung cancer may be classified according to the histological subtypes. So the main distinction between the small cell and non-small cell lung cancer is the histology. The non-small cell lung cancer is the most common variant and accounts for 80% of the lung cancer. So the non-small lung cancer is not small after all. It is the most common variant. Take care. The non-small lung cancer has 3 subtypes: squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. So the adenocarcinoma of the non-small lung cancer is the most common subtype of the non-small lung cancer. But thank God, non-small lung cancer doesn't have paraneoplastic features as much as the small cell lung cancer. So whenever a question scenario in the exam denoting a neuroendocrine differentiation or a paraneoplastic feature, always think for a small cell lung carcinoma. The small cell lung carcinoma is very mean. It named small, but it has many complications and many presentations with the paraneoplastic features that will affect the diabetic patient and the hypertensive patient. All those are paraneoplastic syndromes affecting or affected by the small lung carcinoma. The small lung carcinoma are compromised of a small neuroendocrine differentiation. That's why they manifest paraneoplastic features. The neuroendocrine hormone may be released from these cells with wide range of paraneoplastic association. These tumors are strongly associated with smoking and typically arise large airway. They disseminate in every course of the disease. Although they are usually chemosensitive, they seldom result in long-lasting remission. So the small is not small after all. It's mean. Yes, it's named small, but it comes with the smoker, with many paraneoplastic syndrome and chemosensitive, but there is no long-lasting remission. There will be recurrence. Small is very mean. That's why surgical resection is not beneficial for small cell lung carcinoma, but it can be used with the non-small cell. A very famous question in the exam asking you about a solitary lung metastasis from colorectal carcinoma. Is it better than small lung carcinoma? Yes, small lung carcinoma can't be excised and there will be recurrence rate. But guess what? The colorectal carcinoma with solitary lung mets or if concise to one loop either in the liver or in the lung with one organ in one of them, we are aiming for cure. We can cure this cancer even it's metastasizing because it is slowly progressing. The only cancer that can be cured, even it have mets, but in its early stages confined to one loop and less than 3, you can cure it, the colon cancer. But the small lung carcinoma, without any metastasis, in itself have many recurrence rates. Even it's chemosensitive. Very mean. Don't smoke. A very funny situation you might face it during your practice is you asking you about your patient smoking status. Do you smoke? He will answer you, no, I don't smoke, I only take weeds. These great surgeons take care. The clearest evidence of any malignancy is the invasion of the surrounding structures, especially invasion of the basement membrane. If you cross the line of the basement membrane, this is malignancy. But take care. We all know that the basal cell carcinoma is more common than squamous cell carcinoma and more than the melanoma. In order, the basal cell, then the squamous, then the melanoma. And by the way, now the division of the skin cancers is divided as melanotic and non-melanotic, pigmented or non-pigmented, melanotic or non-melanotic. So, the non-melanotic will be mainly the basal cell carcinoma and the squamous cell carcinoma, and the melanoma with with its subtypes. And take care. In the exam, he will focus on the tumor markers and the prognosis. So, how can you be sure of the prognosis of the basal cell carcinoma? This is a very common recall exam. The basal cell carcinoma prognosis depends upon the completeness of the excision. Nothing else can guarantee the prognosis of the basal cell carcinoma except for the completeness of the excision. But regarding the melanoma will be the Breslow classification thickness. Take care. Don't confuse the grading and the classification. So the Breslow classification thickness is for the melanoma, while the completeness of the excision with the basal cell carcinoma. You have two modalities if you are suspicion for a lesion. Either to do a MOH surgery, you heard it right, MOH, M-O-H, according to the scientist Mohi. So, the MOH surgery depends that the undiagnosed skin lesion to be excised intraoperative with frozen section intraoperative. There will be a pathologist who takes the pathology and cuts it and diagnose it for you to take your diagnosis or not. Otherwise, you take it excisional biopsy, send it for the lab, the result to come to you. Either you need to complete the excision or you are all good and you have taken all your precautions and your safety margin. Take care. So again, the basal cell carcinoma is depending on, yes, the completeness of excision. The melanoma is depending on, yes, the thickness of Breslow. Take care. And of course, the melanoma has a marker, a very famous marker, S100. And when we mention the melanoma, never forget Australia. Australia, melanoma. They have a very huge sun there, unlike any part of the earth. So a very huge concentration of ultraviolet rays, which made them prone to melanoma. I know all of you want to say basal cell carcinoma is more common than squamous and more common than melanoma, but there is a demographic presentation of the melanoma. It's more common there in Australia, and it might be your only key in the exam that a male patient got from Australia having skin lesion that is suspicious. This is mostly melanoma. Take care. Dear great surgeon, you can always take biopsy, whatever the type of the biopsy you are managing for any suspicious mass, except for the liver cell carcinoma and the renal cell carcinoma, there is no biopsy. Even if you are suspecting a mass in the liver, why you take a biopsy? What it will change in your decision? When we take biopsy, the aim is to know how to manage. It's not for the sake of the science and the knowledge. We all know that this is a tumor. This is not right to be here. So we take a biopsy from something to know how to manage it, like the fine needle biopsy in the thyroid. If it's a follicular, so it's not definitive. It can differentiate it's a follicular adenoma or follicular carcinoma. And then you will need a hemithyroidectomy or total thyroidectomy according to it's in one loop or both loop, because a fine needle, if it's in one loop, require hemithyroidectomy and it might require completion of thyroidectomy. Take care. And by the way, let's review some other biopsy types. the seborrheic keratosis, which is very famous differential for the melanoma. It will be multiple scattered superficial pigmented type brownish in the old age people. It's seborrheic keratosis. If you are not sure, you will take it excisional biopsy. But in seborrheic keratosis, to make sure of your diagnosis that this is a seborrheic keratosis, you can always go for shave biopsy. But in melanoma, basal cell carcinoma, or squamous cell carcinoma, if you are suspecting this lesion and you are suspecting one of those differential, you always go for excisional biopsy. You can't go for punch biopsy for any of those. You take it excisional biopsy. And then comes after the reconstructive options. And we agreed that most operation is intraoperative histocytology, histopathology with you that will guide you through your decision when you take it layer by layer until you reach a definitive clear margin space. Take care. In the breast, you will find that fine needle is not as good as the core biopsy. The true cut core biopsy is more definite than fine needle in the breast masses and the breast swelling. You can always go for aspiration in any swelling, cystic swelling, either in the thyroid or in the breast. Go for aspiration cytology. While we have a mass in the breast, please go for core biopsy through cut. But in the thyroid, fine needle might be enough except for the follicular. When we can go for a punch biopsy. Punch biopsy can be used with the Beckett's disease of the breast. By the way, Beckett disease of the nipple have to be differentiated from the eczema. The Beckett will be unilateral, while the eczema bilateral. In Beckett, it's from its name, it's Beckett's disease of the nipple. So the nipple will be destroyed, while the eczema, the nipple will be intact, but inflamed around the areola mostly. The underlying lump in Beckett will usually be present, but in eczema there is no lump below the areola and the nipple. So again, Beckett will be unilateral, eczema bilateral. Beckett will be usually destroying the nipple, while the eczema nipple will be intact. There will be a mass or swelling with the Beckett disease of the breast, while the eczema there is no swelling. Of course, eczema will be itching, but in Beckett there will be no itching. And again, Beckett will be diagnosed with punch biopsy. There is an important biopsy trick you have to always remember. The peptic ulcer is most commonly to be found in the duodenum, so whenever there is a gastric ulcer, consider it cancerous until proven otherwise, and you have to take at least 4 biopsies from different 4 margin in the base of the ulcer. It's a precancerous? No, it's cancerous until proven otherwise regarding the gastric carcinoma. So it's a gastric carcinoma until proven otherwise. Take care till we meet again.